I will just hop over to Facebook. Takes a couple of seconds to get the stream going.
Mm.
And before we go, make sure that people are there. One moment. Happening now. There we go. We are live. All right. Let's not keep the people waiting any longer. Let's start the show. Hello,
Yes.
everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNets program. We have been off for the month of November, a lot of activity in the net space, but we are back. Happy holidays. It is December, near the end of the year. Hope everyone is doing their planning for next year. My name is Rain Bennett. If you are not familiar, I am your host this episode and every episode. And my background is I'm a filmmaker and a writer, and I've been working with CCF for over 10 years at this point, creating many, many videos over that decade plus. Live video series like the one you'll watch today, patient-centric documentaries, which, by the way, we just released one in November. Our latest documentary in partnership with LACNets on Lauren Berlin, a young lady who was who had a lung neuroendocrine tumor, who is getting married and looking forward to the rest of her life while navigating this disease. And so a lot of people in the comments of that chimed in who were also had the same type of tumor. They were happy to see that representation on the screen, which made me very happy, made us feel like we're doing our job. If you haven't seen that, check it out. It's under the videos tab on our page. And all kinds of other video content over a decade plus, but all with one mission in mind, and that is to spread awareness and education about NETs. That is what we are here to do. Now, here at the show, the value, I think, is twofold. One, the information and answers to your question that you'll get from our guest, and two, the shared stories and shared experiences from within the NET community, which is incredibly supportive and incredibly helpful as you navigate this journey. So if you are new to this journey or if you're new to the show, I encourage you to reach out, say hello. You can see the people doing it in the comments. Tell us where you're signing on from. I always love to see how far the program reaches, and embrace this community. I assure you they will embrace you back. That is one of the most profound parts, in my opinion, and powerful parts of this community, is how supportive they absolutely are. So we have been working now with LACNets for many months, maybe this whole year. It's been a while, this partnership, which I'm really excited about. This program, the documentaries that we're creating together, and also, I would say, maybe not most importantly, but very, very important, is the support line that we are able to offer through that. So for anybody, patients, caregivers, anybody that is affected by NETs, please reach out to lacnets.org/support line if you have any questions or support that you need. Now, for today's episode, I am happy to welcome back to the show Dr. Jaydira Del Rivero. Welcome to the show.
Great. Thank you. Thank you so much, Ray. It's a pleasure for me to be here today with everyone. And welcome,
Yeah,
everyone.
absolutely. We're happy to have you back. Now, for those that may not know the vital role that you play in this neuroendocrine tumor community, tell us a little bit about where you work and what you do.
Yes, absolutely. I am a medical oncologist. I'm also an endocrinologist who works at the National Cancer Institute of the National Institute of Health in Bethesda, Maryland. And my area of expertise, and also as well as research, and is in neuroendocrine tumors, including adrenal tumors as well.
Got it. Got it. And how long have you been working in the net space?
Ooh, I mean, I would say about 12 years now. I mean, more
12
than
years.
10 years, 12 years, yes.
Such a active decade it's been, because
Yeah,
I am at least tangentially been working alongside this space in that same amount of time, and just the changes and growth and progress that I've seen is so impressive. So
I know.
for you, it's got
Yeah.
to be amazing.
Yeah, when I initially did my endocrine fellowship here at the National Institute of Health, and at that time I was working with also a neuroendocrine tumor expert, and I was seeing patients with neuroendocrine tumors. But then I left my institution and I went to New York City to build endocrine oncology programs. And I remember then there was not that many options for
Right.
neuroendocrine tumors. It has been about in the last decade or so that there has been more developments on treatment treatment options and more awareness as well of neuroendocrine tumors. So it's been, in a way, a very hopeful time that we can
Yeah.
see these advancements. Yeah.
Absolutely, absolutely. Now, folks at home, just to give you a little bit of information in terms of best practices, you can. There's no limit to how many questions you can ask. Go ahead and start sending them in, and we'll have the queue lined up, and we'll get to as many of them as we can. But it is very helpful for me and our guest for you to ask them in small generic chunks instead of a ton of information. It's really hard to like read that, recite it, and get that information. So the best thing to do is ask them in small chunks, and you can ask follow-up questions. Dr. Del Rivero might ask you for clarification or a little bit more information. If you're still in the call, you can provide that, of course. But that's really helpful. If you know someone, now we've been off for the month, as I mentioned earlier, if you know someone that is usually here or should be here or wants to be here that is not yet, if you don't see them in the comments, you can tag them in the comments, let them know what's going on. You can share this video to their page. We've got a lot of people over on YouTube now as well, which is exciting, but go ahead and start sending in those questions in the meantime, and we will get to as many of them as we can. Let's see. That is all my notes. So go ahead and start sending in your questions and we will get to them. Dr. Del Rivero, I had one question when you were talking about your rather experience and how long you've been working there or working in this space. Who were some of your mentors in the space as you were getting started?
Yes, when I started my endocrine fellowship, I had my mentor was the expert on pheochromocytoma and paraganglioma, and at that time, so for those who may or may know, pheochromocytomas and paragangliomas is a very rare subset of neuroendocrine tumors that affects the adrenal glands, but also some what we call it paraganglia genes, which is localized outside of the adrenal gland, and those are called paraganglioma. So that was my initial exposure in the neuroendocrine tumor field, because as an endocrinologist, part of the management of these tumors is also management of the blood pressure and hormone excess related to these neuroendocrine tumors. And I remember when I started working with a mentor who is an expert on neuroendocrine tumors, his name is Carl Patzak, I realized the need of develop therapies for these patients. At that time, there was no FDA-approved agents. Now we have one, but unfortunately, the company is unable to produce the agent anymore, but we're still working on trying to develop more therapies for this rare subset of neuroendocrine tumors. Then when I left my institution and I went to New York City to develop a neuroendocrine tumor program, I worked with a surgeon who is an expert in neuroendocrine tumors, and I started seeing a lot more patients. But even when I was here at the NIH, I started seeing patients with GI pancreas neuroendocrine tumors, but it was then when I have a full exposure of patients with neuroendocrine tumors. And at that time, I remember I was involved on the earlier clinical trials with neuroendocrine tumors with everolimus and the lanreotide. So I was involved with those studies as well. And then when I was there, I realized that if I wanted to help my patients in a more comprehensive way, then I came back, I did my medical oncology and I came back here at the NIH. I did it at the National Cancer Institute. And then I already knew what I wanted to do. So I was already very focused on neuroendocrine tumors. So I was able to work with different mentors, medical oncologists, as well as pediatric oncologists who sees a lot of cancer predisposition syndromes related to neuroendocrine tumors. And that was a different aspect of that in the management of neuroendocrine tumors as well. That was very involved. And also that time as a medical oncologist and development treatment studies, I was also very involved on helping as well, developing trials and treatment studies, natural history studies for neuroendocrine tumors, how we can collaborate more with the community. So that's one of my roles currently here at the NCI. Yeah.
Got it. Thank you. Folks, real quick, before we move on and start answering questions, I noticed earlier that on the Facebook post, somebody had asked if the program was available in Spanish. So I wanted to address that, especially for our guest today. In the captions section at the bottom of your viewer, I think it says CC on Facebook. If you enable that, it's a little icon on the bottom right side of the viewer. It should populate it with captions in your preferred language, I believe. So hopefully that is helpful, because we want to have as many people and include as many people in the program as possible. So let me know if that works and if that helps. But I just wanted to make mention of that before we continued. So you mentioned, Dr. Del Rivero, some of the clinical trials that you had worked on in the early days. And I know there's a lot of activity going on these days. We often get questions about them, and I suppose that we will today as well. What are some of the what is some of the activity right now in the research stage that you're very excited about?
Oh, okay. Well, there is so many things that I'm
Right. Yeah,
excited
it's a big. It's a big question.
so there are many things that I'm excited about. One of the things that I see has been a lot of development is in the area of theranostics. As we know that 177 lutetium dotatate, or what we also call lutetia, is one of the treatment options for neuroendocrine tumors. And I see a lot of development, and very excited to see the different developments onto this area. Not only doing combination therapies with lutetia. Here at the NIH, we also have a study of lutetia in combination with olaparib, because we know that lutetia is effective for neuroendocrine tumors. What we see is that 20% of less, we see a response. Most of the action of lutetia is a stabilization of disease. So, and even though we work and is one of the treatment options for neuroendocrine tumors, the question is, could we make this treatment more effective? And that's why, we now have combination studies with lutetia. We have one here at the NIH with olaparib. Dr. Shahan at University of Miami has 2 studies as well with lutetia in combination with these other oral medications. And the idea is to make this treatment more effective. How do we make it more effective? And that's kind of like some of the questions that my patients may ask, is that lutetia or Lutathera being a type of radiation treatment, that radiation causes damage of the DNA in the tumor. And your body is trying to repair that damage. It's a compensatory mechanism. So, and when that happens, that sometimes make more resistant, or the tumors could be a little bit more resistant to this therapy. And because of that, by giving a medication or a drug that inhibit that repair, the hypothesis of the question that we want to answer is that that way we can make lutetia more effective. So one of them is lutetia in combination with olaparib. Dr. Shahans have other treatments with the same kind of analogy in terms of trying to make this treatment more effective. Now, we also have the alpha PRRT, and I think that's a very exciting time. I'm not a nuclear medicine physician, but that said, this is an area that we wanted to understand, not about its efficacy, but also where that plays in terms of the treatment options that we already have available. I think that's a very exciting time for me and my research efforts. So what I do is that besides lutetia, could there be other therapies as well? More what we call more targeted therapies. Could we find some specific proteins in the tumor that we could target? And that's kind of like where my research is my research efforts. My research effort is to develop therapies for neuroendocrine tumors, but in order for me to understand what proteins are expressing, I need to understand and study the tumor at the very molecular level. And that's what we're doing, and that's some of the research efforts. At the same time, there is some studies that has been done at Moffitt Cancer Center as well as Italy of the role of immunotherapy, because some of the questions that also some of my patients ask is that, is immunotherapy affected? If immunotherapy work for neuroendocrine tumors? As of now, for neuroendocrine tumors, we don't see that work as well as we can see for the neuroendocrine carcinoma. So I think it's important to differentiate between neuroendocrine tumors and neuroendocrine carcinomas. 2 different biology. One is more slow growing, the other one is more rapidly growing. So immunotherapy tends to work more for neuroendocrine carcinomas, but that said, some of the exciting research is like how we can stimulate the immune system in order to make immunotherapy more effective. So I think that's something exciting to me. We're collaborating also with net experts in Italy that are working on that. I think that's something that I will be more excited to see as well.
Got it. Thank you. Well, we've got lots of questions coming in now, so I'm going to go ahead and start taking some of them. But
Yeah.
per what you were just talking about, Donna had a question that just said, can you explain what immunotherapy is and whether it's useful or not for NETs? Thank you.
Yes. No, great. Thank you. Thank you so much for that question, Donna. And then, what is immunotherapy? Immunotherapy is a series of treatments, because sometimes when I say immunotherapy, sometimes they familiarize that with Keytruda, which is that's a type of what we call immune checkpoint inhibitors. So there are different type of immunotherapies. Keytruda, like what you see in TVs, is a type of immunotherapy. I am working on another type of immunotherapy with what we call a monoclonal antibody, and there is other investigators that are working on different type of immunotherapy. The goal of this is to stimulate the immune system, the patient's immune system, in order to attack the cancer cells. And there's different ways to do it. So that's why we know that we have what we call the immune checkpoint inhibitor. So the Keytruda, like I said, is the one that most often we see announced on TV and the TV. And basically what this medication does is kind of like put some brakes in order to stimulate the immune system to attack the cancer cells. And but there is other ones. For example, I work on another type of immunotherapy, and if I may explain a little bit about that, we call that an antibody drug conjugated. And what that means is that there is three different parts of this, so it's kind of like no one specific thing. So in order to make this antibody drug conjugate, is three different parts. One is what we call an antibody that will basically attack the protein that is expressed in the cancer cell. So the idea of antibodies is going to attach into the protein that's expressed in the cancer cell. And then, but in order to do that and to go inside the cancer cell, there is going to be what we call a linker that goes with the chemotherapy, and that will help go into the cancer cells. And the idea is that can call cancer killing, and that's killing of the cancer cells. So that's kind of one type of immunotherapy. There are other ones as well that stimulates the immune system, certain cells in the immune system, so that way they're able to then be able to attack the cancer cells. The question was about whether it works for neuroendocrine tumors. I think I mentioned this briefly earlier, that immunotherapy, the classic immunotherapy that has been approved, like the pembrolizumab or Keytruda, that's the name, we don't see that is as effective as we have seen with neuroendocrine carcinoma. So again, there's two different type of we call neuroendocrine neoplasm. So there's two groups. One is neuroendocrine tumors, they're more slow growing, and the neuroendocrine carcinomas, they're more rapidly growing. So, and immunotherapy seems to work better on the neuroendocrine carcinomas as well. Hopefully that answered the question.
Yeah, got it. Thank you. And thank you, Donna, for your question. Moving on, Mark says, I just had 2 nets removed, but an infected lymph node was not able to be removed from my intestine. It was debulked. What is the best follow-up treatment for the remaining part of the node? It is grade 2, by the way.
Okay, great. Thank you for that question. So first we need to understand what neuroendocrine tumor is. What we call the primary site, whether it's a small bowel or a small intestine neuroendocrine tumor, or whether it's a pancreas neuroendocrine tumors or any other size of disease. I think it's important to know first what we call the primary site, because sometimes in terms of knowing the primary site, there is also going to be some different treatment options as well. Now, in terms of whether it's a pancreas or small bowel neuroendocrine tumors, if there is a lymph node, I can understand. Sometimes I'm not a surgeon, but I can understand based on where the lymph node is located. Sometimes it's very difficult to get there. And sometimes the surgeons, even my surgeons, may say, oh, well, I did the surgery, but there was a couple of lymph nodes that we need to follow up. So in those situations, we usually follow with scans. The reason why I'm saying it's important to know primary tumors is because also of the hormones related to the tumor type. For example, pancreas neuroendocrine tumors, less than 30% may produce excess of hormones, and based on what hormones it produces may have different clinical manifestations. And the small bowel neuroendocrine tumors, when it's already in the liver and other areas. So sometimes it can produce serotonin, and that can cause symptoms related to excess serotonin, or what we call carcinoid syndrome. So it's important to understand where the tumor, where the primary is, as I say, small bowel, pancreas, or other sites of disease. It's important to know whether it's expressed hormones or not, because there may be certain treatments that may be needed in order to control the excess of hormones if the patient has symptoms. Now, based on that information, and if there is only one lymph node that is, we think is there, is left behind, so we usually follow with scans. The frequency of scans is after surgery is anywhere from 4 to 6 months for the first 2 years, just to understand what is the growth behavior. And then after that, if there is no any changes in growth, then we usually follow scans once a year. My preference is that I usually do CTs or MRIs in order to follow these lumps, lymph nodes, or any other areas of disease. But if I feel like there is any changes, or that I see more lesions, then I will do what we call a 68 gallium or 64 copper dot-to-tape scan. So that's kind of like my usually approach. What we call anatomical image studies, either with CT or MRI. I don't necessarily do every 6 months or 4 months a gallium scans. I do it when I see there is a changes on the CT or the MRI. Now, the only condition, just to kind of like make clarification, where I follow patients only with a gallium scan, is when I see that there is bone lesions, because sometimes it's very difficult to see either with a CT or an MRI. So in those situations, it's better to follow up with a gallium scan. And that's in terms of the follow-up, but also understand the symptoms, because based on symptoms, there may be other measurements as well that needs to be done.
Absolutely. Thank you so much, Mark. Thanks for your question. Let me know if you have a follow-up. Next question from Dorinda.
Right.
I'm taking a break from Captam, and I have developed shingles. Could these be related?
Yes. Well, thank you so much. So capecitabine temozolomide is a type of oral chemotherapy, and that tends to suppress in part the immune system too. So usually medications like temozolomide sometimes can lower certain cells, especially the white blood cells. We know that those cells are the ones that fight infections. And sometimes when the immune system is a little down, so sometimes they can place a patient at risk to develop other conditions such as the cold or even shingles, especially in somebody who is already predisposed to have the shingles. I just want to make a clarification. Captain doesn't cause shingles, but if you already have and virus, and because this shingles is a dormant virus, it's usually the ones that were already had chickenpox as a kid. Sometimes the virus are dormant, and then sometimes it's exposed as shingles. So already the virus is there. Sometimes when the immune system is down, then it can happen that the shingles appear. But that's kind of, just a clarification, Captain doesn't cause shingles. It's just that the virus is already dormant, and when the immune system is down, other conditions, we can see that presentation as well. And of course, depending on age, that's the reason why it's recommended to have the shingles vaccine too.
Got it. Thank you. And thanks for your question. Next one comes from Jill. I don't recall if we addressed this when talking about clinical trials earlier, but the question is, what are the latest treatments or research for metastatic pheo?
Yeah, I can definitely talk a lot about that, because that's
Yes.
one of the
I know.
that's one of the research that I do here at the NIH. So there is just for those who knows or doesn't know, pheochromocytomas and paragangliomas, as I say earlier, is a very rare subset of neuroendocrine tumors that is either localized in the adrenal gland, which is called pheochromocytoma, or outside of the adrenal gland, which is called paraganglioma. Up to 40% of patients with pheochromocytomas and paragangliomas may be associated with a germline pathogenic variant, meaning that it could be hereditary. Up to 40% of patients that have pheopara. So that's the reason why every patient that have pheochromocytomas and paraganglioma needs to see a genetic counselor, so that way they can do genetic screening for that. Depending on what mutations the patient may have, sometimes there is a higher risk to develop more metastatic, what we call more aggressive disease or metastatic disease. And because of that, sometimes the follow-up may be different as well. Now, when there is a patient that had metastatic disease, as well as with the management of neuroendocrine tumors of the GI, pancreas, and lungs, we need to also understand number one, where is, if it's in the adrenal or outside the adrenal gland, because as again, most of the tumors outside the adrenal gland are the ones that has been associated with a familial syndrome. We also need to understand the extension, how many tumors we see on the scans, but also understand, what is the growth rate. Based on that information, sometimes we can target these tumors with different therapies. And we have treatment options available for pheochromocytomas and paragangliomas from chemotherapy, also included with lutetium as well. Those are the treatment options as well. And also we have what we call targeted therapies, meaning that they can target certain proteins that is expressed by the tumor. Those are called sunitinib, cabozantinib, and those are treatment options for this tumor type. But also similarly to other neuroendocrine tumor, surgery can also be considered as well. Not everyone may benefit from surgery, but it's something that needs to be discussed. So that's the reason why, we always say, the neuroendocrine tumors needs to be discussed with a multidisciplinary team that has medical oncologists, endocrinologists, nuclear medicine surgeons, and so forth. So that way we can then give the best treatment options to the patient. Now, when we don't have those treatment options available, or we feel that those treatments, doesn't work for the patient, then is that we need to consider treatment studies or treatment trials. And we have quite of them available, actually, and we have quite a few of them available here at the NIH. We have a study of lutetium for patients with pheochromocytoma and paraganglioma. This one is ongoing. Similarly, there was tissue, as we know, is approved for small bowel, pancreas, neuroendocrine tumors. We are doing the study for pheochromocytomas and paragangliomas. We also have another study of the oral chemotherapy. It's called temozolomide in combination with olaparib. So, and just to explain a little bit about the study is that temozolomide is a type of oral chemotherapy. It's already indicated in treatment guidelines for pheochromocytomas and paragangliomas. But the question that I mentioned earlier with the tissue, could we make temozolomide more effective? So temozolomide, similarly to lutetium is a type of radiation therapy. Temozolomide is an oral chemotherapy that can also cause damage to the DNA of the cancer cell, and the body is going to try to repair that. But when that happens, like I say, sometimes the tumor can become more resistant to these therapies. And by adding olaparib, which is an oral drug that has been approved for other cancer types, prostate cancer, breast cancer, we're trying to prevent that repair to make temozolomide more effective. So that's a treatment option that we also have available here at the NIH. It's a treatment study. We also have a study of lanreotide. So lanreotide, we know, is approved for small bowel, neuroendocrine tumors, pancreas, lungs, but not necessarily for pheopara. So even though it's a type of neuroendocrine tumors, and we also indicated for those patients as well, but it's important to have the study that can really prove its efficacy, so that way we can submit that information to the FDA, and that way we can make it available for everyone. We also have another treatment study as well. I mentioned earlier about the antibody drug conjugated. So pheochromocytomas and paragangliomas also express this protein in the surface of the cancer cell. And with this treatment, we call antibody drug conjugated, we're trying to target that protein that is expressed in many neuroendocrine tumors. Neuroendocrine tumors of any site, including parapheos. And because of that, we also have the studies more on the early phase. So when I say early phase, I mean phase 1. So phase 1 is to determine safety and also to determine what is the best dose or the maximum tolerated dose in patients to then move to the phase 2. But as we can see, there are many treatment studies. I think I saw somewhere about belzutifan. Somebody asked about belzutifan for pheochromocytomas and paragangliomas. So besultifan is approved for VHL-related tumors, so meaning for kidney cancer, pancreas, neuroendocrine tumors, as well as for hemangioblastomas, formation of tumor, blood formations in different parts of the body, mainly the nervous system. And besultifan has been approved for that one, for those cancer types, but it has not been approved for pheochromocytomas and paraganglioma. So that's the reason why the company did the study. But also they wanted to understand if it could be effective for other pheochromocytomas and paragangliomas not associated with VHL. So that study finished is accrual, so it's closed for accrual. So the company is analyzing the information. So we still need to know, whether this can also be indicated for other type of pheochromocytomas and paragangliomas not associated with VHL. So we're still waiting for that information. I cannot tell you whether it's effective or not. I can tell you that it's effective for VHL-related pheos and paras and other tumors related to that, but we still need to understand whether it works also for other type of parapheos.
Got it. Thank you. Great question, Jill. A lot of good information there. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, Carcinoid Cancer Foundation and LACNet's program. Today we are here with Dr. Del Rivero from the NCI. Great questions so far. One question I have for you all at home. Today, I made an event on YouTube and Facebook. Oftentimes, it's not for the people who are here every episode, but we often get questions of like, where do I sign up or where's the link? And there is no link because you just go to the profile. We go to YouTube and we go to Facebook simultaneously. But I did, through this software, I created an event today that is populated on the Facebook and the YouTube, so you can see it as it's coming up, and then that's where you would go to join. Let me know if that it was helpful at all. I'm not sure if it was, but some people continue to ask that kind of question, so let me know if that helped, and I'll totally continue to do it. Okay, next question. You okay with a lung net question?
Yep.
Yep. Kathy says, I had 2 nets removed from my lung. During the surgery, I was found to have hundreds of tumors in my pleural space. I am not finding treatment options. How should I proceed?
Okay. So the question is like 2 tumors were resected with surgery and there are multiple seen on the pleural space. Is that, but it's
Yes.
currently seen on the pleural space? Is that?
That is what
what
I'm
it is?
understanding. During the surgery, I was found to have hundreds of tumors in my pleural space, but I'm not finding treatment options for that, I guess.
Okay.
How should
Okay.
I proceed? Yeah, okay, cool.
Yes. Okay. So, and just one clarification. I think I want to make a comment mainly for the purpose of education to what my
Please.
understanding is on that question. That say, in order for me to really make an opinion, I really need to look at scans. I really need to understand, more of what the patient's conditions and so forth in order for me to make a good recommendation. But that said, in terms of the pleural, because you're talking about the pleural space, so basically it's kind of like the layer, that covers the lungs. And in that situation, and that's kind of like done. There is another condition, a cancer type called mesothelioma, where it kind of like affects the pleural space as well. And sometimes there may be specific treatments that targets that space. We call that I'm blanking on the name because that's not something that we necessarily do, but is done mainly in patients with mesothelioma. But basically what they're trying to put is a type of either a specific drug in the pleural space in order to address those tumors. But that's, I think it's important to understand, and whether this is related to the neuroendocrine tumors is hard for me to really set that, because neuroendocrine tumors going to the pleural space is not something that happens. If it happens, it's super rare. I personally have not seen only in the pleural space, but that's the same concept of how mesothelioma is treated, because affect that space as well. There could be treatments that could be given only in that area. So there are different type of drugs, chemotherapy, even certain substance that can be added on that area to target that. But again, whatever I'm saying right now, please take it with a grain of salt, because in order for really make that recommendation, I really need to look at the scans and understand exactly, what's going on.
Of course, of course. Thank you, Kathy. Appreciate your question. Next one comes from over on YouTube. My husband passed away with carcinoid syndrome in 1992. Sorry to hear that. But now my 41-year-old son is having some symptoms. I'm sure that's scary. And his doctors are having difficulty diagnosing him. So the question is, other than 5-HIAA test, what else is there for diagnostics?
Okay. And thank you for that. And just another clarification, I think it will be important to know more
Yes.
about it, look at what symptoms they are, and so that way I can provide more guidance. But one of the things that I mentioned earlier is that neuroendocrine tumors can also produce certain peptides or hormones. And depending on what hormones the neuroendocrine tumor produced, then we have different clinical manifestations associated with that. Now, the thing that the question was, well, my husband has a neuroendocrine tumor, and I'm really so sorry to hear about your husband. But that says like what kind of neuroendocrine tumors, whether it was small bowel, whether it was pancreas, because based on that, they may have different clinical manifestations. If the question is, does my son has a neuroendocrine tumors, maybe because he has similar symptoms related to my husband, I think is something that will need to be explored as well, and what symptoms they are. If there's a neuroendocrine tumor as a small bowel that may produce excess of serotonin, usually, how we measure that is via 5-HIAA, either in blood or in urine. But again, in order to understand if there is an excess of serotonin, there has to be specific symptoms such as diarrhea, flushing, and also wheezing. So there is specific symptoms related to that. Now, if the neuroendocrine tumors came from the pancreas, and then and the pancreas was a functional tumor, so there will be different clinical manifestations. We have neuroendocrine tumors of the pancreas that produce excess of insulin. So this excess of insulin is going to lower the glucose. And so we translate that as low glucose and symptoms of what we call hypoglycemia, because meaning low glucose as well. So there are very specific symptoms related to that. If the pancreas neuroendocrine tumors produces gastrin, so gastrin is responsible for the secretion of acid production. So, and if there is too much acid in the stomach, that will place a patient to develop a risk for ulcers, and that also been associated with diarrhea and bleeding. So, depending on what hormones the neuroendocrine tumor may produce, then we have the very specific clinical manifestations. Now, as I mentioned earlier, if you ask me what is the percentage of neuroendocrine tumors that can be hereditary, is less than 10%. Okay. So, but most of the time we have seen it associated with the pancreas neuroendocrine tumors. And usually there is other clinical manifestations associated with that. I think it's important to recognize what symptoms they are. Yeah. And then based on the symptoms, then there could be other peptides or hormones that can be measured. If the question is like whether it's hereditary or maybe what my husband have, my son may have, I think that will be something that needs to be discussed as well, based on what kind of neuroendocrine tumors your husband have, and then understand more about the symptoms associated. But I mean, I'm happy to provide my email or my information. If there is anything else that I can help, please reach out.
Oh, yeah, I appreciate that. And folks, this is, and by the way, there's a question later about NETs being hereditary too, so you kind of already addressed that. But folks, this often happens where there's more information needed to really give the proper guidance. We can give generic advice in this format. So oftentimes our guests say like, hey, it depends on these few things, these variables that you may need to go or gather or whatever. I want you to know that this is not your only opportunity. I want to reiterate what I said in the beginning. Reach out to lacnets.org/support line. We'll try to put the link in the comments here. That is what we are here to do, is to continue to provide support. Now, we just inevitably can't get to every question every episode, but that's why we keep having episodes every other week. But that's a way in the meantime, you don't have to just wait for the show. You can always reach out and we'll try to give you the guidance. And most of our guests are very helpful, like Dr. Del Rivero, and happy to take calls or emails as well, too. I don't want to sign you up for that, but most of the time people are very open and flexible with what they offer, their time. And for you, Dr. Del Rivero, if there are any questions where you need some more context, most of the time people tune in for the whole show. So we can also say, like, hey, Rain, if you let me know what grade this is, I can give you a better answer or something like that. We can also do that that back and forth as well. Okay, moving on. Let's see. Immunotherapy. Okay, so William, who is not far from me here in North Carolina. Hey, William. William was diagnosed with a PNET 2 years ago. And the question is, how long can I continue on Captem? I'm currently on my 16th round. The tumor has shrank almost half, from 6.8 centimeters to 3.4. So that's good news. But the question is, how long could I continue on Captem?
Oh yes, that's a very good question. And the fact that it shrank half, this is very good. So not everybody can have shrinkage of captain, but what we know, especially for pancreas neuroendocrine tumors, is that captain is a good option to shrink tumors. And we know that at least 40%, we can see a shrinkage of about 40% or more in some patients. So the fact that, William, is you're having these experiences, this is good. Now, how long? So, and that's kind of like always a discussion between the net experts. So I think that usually the recommendations is that we give captains anywhere from 6 months to 12 months. Now, if after 12 months we see that the tumors is still getting smaller, so maybe you want to continue longer than that. So I know that Dr. Jonathan Strasberg, who is a well-known net expert and nationally, internationally recognized, sometimes he may continue a little bit longer if there is a benefit of CAP10, but usually the recommendations is 6 to 12 months. Now, if the tumor shrank that much, maybe one option will be to discuss with your medical oncologist. Maybe they could discuss it with a surgeon. So, because maybe there is an opportunity to remove all tumors that are seen on the scans. I mean, I don't know, because this is just more for educational purpose, so difficult for me to really make a recommendation without looking at the scans, but it's always an option if you shrink that much. So maybe a consideration will be to discuss with surgery whether they can remove all those tumors, and of course based on where they are locating, and that will be an option if that, I hope that answered the question.
Thanks, William. And I feel like this might be your first time here. If so, welcome. Appreciate you being here at the show.
Yes.
Next from Tammy. Tammy says, I have multiple tumors in both of my lungs, and it's been a year since diagnosis. Still no treatment plan, and the last oncologist said he didn't have any treatments. And I know that's got to be frustrating, Tammy. Sorry to hear that. I've asked about PRRT, and they don't want to do surgery, but won't give me other options. I'm stage 4. Please help me know what I can do. Yeah, that's a tough situation, Tammy.
Yeah, I know. Sorry. I mean, I can imagine that must be very difficult. So, well, based on what is said, it seems that there is confirmed neuroendocrine tumors in both lungs. And if there is in both lungs, I think we need to understand exactly where they're located, what are the size. So it's hard, for me to make a comment on that. But I think one of the aspects of lung neuroendocrine tumor is that we need to understand, the grade as well. Similarly to pancreas and small bowel neuroendocrine tumors, that, we kind of like, how do we know, whether it's well differentiated versus more or poorly differentiated, is by looking at a number that we call Ki67. So Ki67 is a proliferation index. It tells me how the cells are able to divide, and does look under the microscope. Similarly to that, we see on the lungs, we need to understand also what is the grade as well. We call that typical or atypical. So sometimes that can be a little bit more complex, but typical is more well differentiated. Atypical meaning that the gradient is a little bit higher. So I think it's important to note that, because sometimes there may be other follow-ups and even treatment options that could be recommended. a Gallium scan can certainly, or a dot-to-day scan can certainly be helpful, whether the lung neuroendocrine tumors express the receptor. Now, approximately half of lung neuroendocrine tumors may be positive on gallium or dot-to-day scan. Not every lung net is positive on these scans, compared to more of the GI pancreas, up to 90% may be positive on the gallium scans. For lung neuroendocrine tumors is a little bit less, about 50%. So, and because of that, that can also help establish, what treatment options are available. Now, if the lung neuroendocrine tumor is positive on the dot-to-day scan, so yes, it's possible that lutetium could be an option. That said, it's not approved for lung neuroendocrine tumors. There is an ongoing study. It's a multi-center study, so there are different hospitals that have the study. The study is led by Dr. Tom Hope, and he's a UCSF, University of California in San Francisco, who is one of the lead investigators on this study. So it's ongoing. So that's for lung neuroendocrine tumors. But there's also other options as well, other options for lung neuroendocrine tumors, depending on where they're located, depending on the site, depending on how much. There is also other therapies such as CAPTEIN. I'm sure some of you heard CAPTEIN, combination of capecitabine, temozolomide, everolimus is another option. So there are options for lung neuroendocrine tumors, but I think it's important to understand it's important to understand where the tumors are located, how much there is, whether it expresses somatostatin receptors or not. So that way, we can tailor treatment options for the patient.
Got it. Thank you. Appreciate your question, Tammy. Let me know if that helps, and if you have any follow-ups. From Mary. Mary's question is proton therapy ever used for neuroendocrine tumors?
It's a proton therapy is a type of radiation or localized radiation, so it can't. So when do I recommend? For example, I recommend it, for example, when the neuroendocrine tumors are also in certain areas of the body, maybe the bone area. So especially if it's not that many areas and it's causing some pain, radiation can be indicated for that. There is also certain areas in the liver too as well. So that maybe there's other therapies that has been given to the patient, but then there may be some areas that need to have further control of growth. Sometimes that type of therapy can be indicated. I don't think it's something that has been used as widely as we have used, for example, with lutetium or other therapies, but I think it's now more people are starting to use this type of therapy for certain areas, more localized areas that need to have control of growth. So that's when it may be indicated.
Got it. Thank you. From Jill, is there any update on the belzutifan trial for pheopara?
Yeah. Thank you. I mean, I was earlier was explaining that belzutifan is approved for VHL-related tumors such as hemangioblastomas of the nervous system, pancreas, neuroendocrine tumors, as well as kidney cancer associated with VHL. Has not been necessarily approved for parapheo, so that's the reason why the study is ongoing for that. That said, pheochromocytomas and paragangliomas associated with VHL, they rarely go to other places, meaning they rarely metastasize. But we still need to understand maybe a large tumor, whether it shrink the tumors, as we have seen with other tumor types related to VHL. Now, the company also opened a cohort of patients when I say the company, Merck is the one who's leading the study, opened a cohort of patients for Theos and paras not related to VHL. So any type of pheopara, it could be sporadic or succint, or the ones that has been associated with other genetic mutations. That cohort of patients is closed for accrual, but we still need to understand, whether it works for other types of Theos and paras that are not related to VHL. Why they wanted to do it in other parapheos is because what we know is approximately 40% of patients of parapheos may have a VHL mutation. So we have VHL germline, which meaning that it runs in families, or whether it's only in the tumor. And that's the reason why, they're doing the study. But also in patients that have other mutations, like succinate dehydrogenase mutations, um, this mutation can cause a low oxygen state within the tumor, and because of that, that can also promote some growth, tumor growth. And this Vesultifan is supposed to also target this low oxygen state. So that's the reason why, we wanted to understand, but we still don't know the result. We eagerly waiting for the results. So I think more information should come in the next year or so.
Got it. Thank you. And thanks again, Jill. From Sean, are the immunotherapy utilizing genetically modified or RNA technology? And do all immunotherapy treatments turn off the body's own immune system to accept those new immune cells?
Yeah, that's one of the goals of immunotherapy. Though it's different ways to stimulate the immune system, to stimulate the T cells, what we call one of the immune cells in the body, in order to then attack the cancer cells. So that's the role of immunotherapies. So as I say, there is different type of immunotherapy. I know that the question that he's asking is more in the research aspect of kind of genetically modified type of this gene therapy and so forth. I think that in that situation for neuroendocrine tumors, we still need to learn, but I know there is some research trying to understand that part, but that's all I can answer.
Got it. Thanks, Sean. Folks, we got just shy of 10 minutes left. We're going to keep moving forward and answer as many questions as we can from Larry. Larry says, I've had difficulty obtaining images through CT and MRI of a PNET in the head of the pancreas and hip. Moving forward, we will use dotatate PET scan. Mm-hmm. Is there a downside to the dotatate scan every 6 months?
Not necessarily. I mean, sometimes with the Gallium scan is that insurance companies sometimes may not necessarily approve every 6 months scans, but if the insurance company is willing to prove it, and in this situation you have a very good argument because you say like we're unable to see it on the CT scan, we're unable to see it on the MRI. So in that situation, I think dotatate scans can certainly be very helpful for follow-up. And if you're asking about downside of radiation, I personally don't think that there is something concerning in that area. So, but if your primary oncologist wants to do that, follow with that, because unable to see other areas with the CT and MRI, I think it makes a good argument, and they can discuss with the insurance company to get it approved. As I mentioned earlier, that an indication that I do recommend a dotatate scan is in bone lesions or bone metastasis, because we know that CT or MRI are not very good for bone. So in that situation, it's important to follow those patients as well with a dotatate scan.
Got it. Thank you. From Lopez, on behalf of his mother, my mom has a question. She recently had an MRI that showed a new small tumor under her liver. She wants to know if this could cause new symptoms, as she is experiencing a swollen stomach and any touch to her stomach is causing pain. Let me know if you'd like further adjustments. I think meaning to his wording.
Mm-hmm. Yeah, right. Thank you. Maybe could you repeat again the question?
So my mom recently had an MRI that showed a new small tumor under her liver. She wants to know if this could cause new symptoms because she's experiencing a swollen stomach, and any touch to her stomach area is causing pain.
Okay.
I'm not sure.
Yeah. So I really want to help answer this question the best I can. But when you say under the liver, exactly where it's located, on the rib, more closer to the stomach, I think it will be important to obtain more information in order to really understand whether symptoms may or may not be related to that. Sometimes it can't. And maybe what the question is, like, maybe there is a lymph node or that may be closer to the stomach, but sometimes kind of like underneath the liver. I think that will be something that we'll need more information in order to determine whether that could cause the symptoms.
I believe Lopez was the participant asking about the Spanish subtitle, so this may be getting lost in translation because I think he is still trying to ask the question in English, even though it might not be preferred. So hopefully we can connect offline and get him
Yes,
some
absolutely.
answers to his for his mother. But thank
Yeah.
you, Lopez. We'll try to continue this so that we can get you some answers.
Yeah, and Ray, as you mentioned earlier, I mean, Lackness has certainly reach out to Lackness. They are phenomenal on trying to help patients and trying to answer some of the questions the best they
Absolutely.
can. They can do it in Spanish, and if I can help, Spanish is my first language.
Right.
Absolutely, I can certainly help.
Okay, lovely, lovely. So we'll try to reach out to you, Lopez. And for those on the back end, Lopez commented on the announcement graphic that we posted earlier in the week. So we should be able to find them hopefully. Okay, a couple more questions with the 5 minutes that we have. Okay. Aaron says for someone who has high grade progression from a previously pulmonary atypical carcinoid with large cell neuroendocrine
Mhm.
carcinoma, represents 25% of neoplastic tissue. Ki-67 is over 70.
Mhm.
What would treatment options potentially be? When they were originally diagnosed,
Mhm.
Ki-67 was 10 for the atypical neuroendocrine. Does that make
Mhm.
sense? Do you follow that?
Yes, I'm. So the way I can answer this is that so what I understood is like it seems like now the diagnosis is a large cell
Mm,
lung uh, neuroendocrine carcinoma.
mhm,
So whether sometime back, they did a biopsy, and the biopsy said that the Ki-67 was a lot lower than what it is now. Sometimes we need to understand exactly where the biopsy was taken from, because if the biopsy was taken from an area that has a lot of what we call necrotic tissue, dead tissue, maybe that number of the Ki-67 may not be as accurate. But that said, the fact that we have a number which is 70 and is also the pathologic description of large cell, so that may be more in the kind of like on the classification of neuroendocrine carcinoma, for which the treatment is completely different than what we say for a typical lung neuroendocrine tumors. And usually for the large cell is usually with chemotherapy. There are different chemotherapies as well. Cisplatin and etoposide immunotherapy is an option. I think the fact that we have the diagnosis of K67, I think, of 70% with large cell, so that needs to have a specific treatment options, which is more on the neuroendocrine carcinoma.
got it. Thank you so much. From Samantha, would you see any concern with receiving a lanreotide injection every 21 days versus every 28?
Mhm. So yeah, that's a good question, because I think that when do we give it every 21 days versus 28 days? So the indication of these injections, either sandostatin or lanreotide, is every 28 days. But sometimes we give it every 21 days if we feel like we need to have improvement of symptoms, mainly diarrhea or flushing. We feel like by the third week, because usually what patients may say, well, by the third week I start having like more diarrhea, I don't have the same effect. Sometimes a lot of net experts may say, well, let's give you the lanreotide every 21 days instead of every 28 days, because to improve the symptoms. So that's the reason why we do that. The reality is that we don't have a lot of data, but it seems based on clinical practice, it seems that can certainly help. Now, if the question is like, well, can I have more side effects, or it's going to be, long term, whether that could affect me more, whether it's 21 or 28 days, yeah, I don't think that that's any case related to that. But the indications is because we wanted to improve the symptoms, that we're doing a little bit shorter, 3 weeks rather than 4 weeks. But in terms of long-term side effects, it will be the same.
Got it. Next question from Dusty over on YouTube. Hi, I have a tumor in my left ventricle. It is not large and it is stable, but I'm wondering how common this is.
Okay. When I so in, Again, sometimes I put my paraphio hat here.
Right, right.
So when we say left ventricle, is that a metastasis, from
Okay.
coming from the small bowel, from the intestine that goes there. I have seen it. It's very rare, but it can happen.
Uh-huh.
Whether it's because of the lung neuroendocrine tumors that very close to the what we call the bronchial tree that is also invading, or whether we have what we call cardiac paragangliomas as well. So I think important to know whether it's a metastasis or coming from the lungs, or also whether these are primary cardiac paraganglioma. So sometimes I put my, like I say, my paraganglioma hat, but I think it's important to know where is this coming from in order to then recommend treatments options, because we know that if this is a metastasis, maybe a little bit different than if this is primary from the lung or primary from a cardiac paraganglioma.
Got it. And speaking of which, we have one final question today. What is the best way to detect a pancreatic paraganglioma?
Yeah. Well, so I mentioned a little bit earlier that we have pheochromocytomas and paragangliomas, right? Pheochromocytoma is in the adrenal gland. Paragangliomas is anywhere neck, chest, abdomen, pelvis, outside of the adrenal gland. So it could be anywhere. And it's important to know exactly where it is in that area. So if it's localized, let's say if we think that this is in fact a paraganglioma, then if it's localized, sometimes we need to discuss with surgery whether that could be resected. In the setting of familial syndrome, we need to understand whether there is any other areas, because could that also be a metastasis to the lymph nodes? If we're thinking that it's a paraganglioma, yes, could that? So I think it's important. Sometimes what I have seen, and it happened even with neuroendocrine tumors, that sometimes it can go to a lymph node very close from the pancreas. And sometimes it's difficult to kind of like differentiate on the CT scans. We have seen that in quite a few patients. It's a lymph node, and we think this is a pancreas a neuroendocrine tumor. But sometimes, may not be necessarily a pancreas neuroendocrine tumors, maybe a lymph node metastasis for small bowel neuroendocrine tumors, similarly to paraganglioma. So we need to know exactly what it is, whether it could also be a paraganglioma of the pancreas. It can happen. Neuroendocrine tumors is anywhere in the body. It can happen anywhere in the body. So it can also be in the pancreas. It would be super rare, but it can happen. But I think it's important also to not only do the needed imaging studies, but also for pheos and paras is the hormonal evaluation as well with pheochromocytomas and related to pheo and para. We need to obtain hormones in order to understand whether the tumor is functional or not, because again, there's different measurements that needs to be done in those situations, and also genetics, as we discussed earlier, important to do genetic cancer as well.
Got it. Thank you. And thanks, Lucy. Hopefully that helped answer your question. Folks, that is our show for today. Robin says, I'm glad you all are back. I missed the luncheons. Thank you for what you do. Absolutely. And thank you, Dr. Del Rivero, for being here with your lovely zebra scarf. I appreciate you so much.
Great. Thank you. Thank you so much. A pleasure to be here.
Absolutely. And yeah, we are back, Robin. Took the month off, and we're excited to be here. Just one announcement before we go. We will have one more before the end of the year. So 2 weeks from today, it's December 19th. And you can stay tuned for the news of what's coming next year, but we will be back in 2 weeks for one final episode of 2024. Crazy, right? And you all were very clear that it did help when I created the event today, so I will be doing that moving forward for you. Thank you all at home for being here. As always, we hope that this program helped answer some of your questions. Again, I'll reiterate, follow up with LACNets at lacnets.org/support line. If you have follow-up questions, we put that link in the comments. But we appreciate you being here. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next